So next is Dr. Asif Hussain. Dr. Asif Hussain, he will be presenting on broken implant, revision hip arthroplasty, a case report, do's and don'ts.
सर वो ओरिजिनल नहीं है।
अच्छा अच्छा अलाउ ना खोलो खोलो कैसे करना है Good afternoon to all. Today presenting case of broken implant revision hip arthroplasty, sir. Sir, this is a case of a 45-year male who come to me the history of fall on the ground. And after that, we found that there is a presence of broken femur prosthesis, neck femur. Then previously cemented THR was done 6 years back. Patient is having no comorbidities. Then we go for the X-ray. X-ray, we found that there is a broken of femur prosthesis neck. Then we plan for this patient. First I evaluate the patient, either he is fit for surgery or not. Then go for the investigation to rule out either there is some infection or not. Then the plan for the surgery. So before the surgery, we found out what the cause for the femoral prosthesis stem fracture. Femoral stem fracture is generally thought to occur due to the fatigue generated by unfavorable biomechanism. Means sometimes loss of the proximal support with the well-fixed distal stem. Poor design, manufacturing defect can lead to increased stress and fracture. Loosening of the implant, infection, patient factor, implant and surgical factor, improper placement of the sizing, malpositioning of the implant, so many factors. So for the technique to remove, already sir explained, for the cemented cup removal, we go for some literatures and found out. These are the in-top images. I use the posterior approach. Here we remove the stem through the drill and make the V and do all these things. This is my post-op X-ray. I make the version correction of the cup also. There is no infection in that, and use the stem. And I didn't remove all the cement. I used the cement as a restrictor and put the cemented stem. These things I removed. This is the second day of the patient post-op. With support of crunches. And he is walking without support. And this is the day before yesterday's picture. So the take-home message, the regular monitoring and maintenance of the implant is crucial. While choosing an implant, it is essential to consider material property, design feature, and patient-specific factor to minimize the risk of fracture. But fall-related implant fracture are possibilities, sir. Avoid malpositioning of the implant. Implant quality is crucial, but surgical skill is paramount. Patient education and rehabilitation are the key, sir. Thank you.
Can you put the first X-ray before you leave? Just the first X-ray before you leave. Just the first X-ray for 10 seconds. That's all. Thank you. Yeah.
Yes, thank you, sir.
For later discussion, I think we remember.
Thank you so much, Dr. Asif. I would like to call upon Dr. Uttam Garg sir for his talk on revision hip after hemi replacement in a broken stem.
Thank you, sir. This is not my X-rays. That's it? So it's just a case presentation. इधर नहीं आ रहा इधर. Okay. नहीं. Yeah. So it is a 40-year-old male with non-diabetic with a right THR done about 2 years back, come with a pain and instability. On examination, there is no redness, local temperature is normal, no sign of the infection. Investigations, everything is all right, CRP is 1.5. So, it's a paralytic. Sir, I will like to ask you,
So if
you need any further investigation for that one?
No, unlikely, because stem broken could not be because of infection,
Yes.
We don't suspect so. It
Agreed.
could be because of other reasons, but broken stem could not be because
But you routinely, you go for the joint aspiration or no?
So I always think, could it be infected or not? Like this kind of case? Very highly unlikely to be CRP minus
It's not
1.9.
likely.
But yes, when I suspect infection, like I ask, I keep on getting international patients also. Because I'm aware of the fact, despite being CRP normal, one can still have infection.
Exactly.
I got a case
Yeah.
and I burned my hands, but we could come out. It was aspiration negative, it was negative, CRP negative. I do aspirations majority of times, to be
Okay.
honest.
So frozen shock section? Frozen section?
Yes, it came in frozen section. I'm talking of my case, CRP was normal, aspiration did not grow anything.
Okay.
Did frozen section, it was bad. We did 2 sets, it grew pseudomonas, the membrane grew pseudomonas later on. So a normal CRP does not rule out infection. But then suppose a case comes to me 20 years after hip replacement, because of life of the implant, I don't expect infection. So not every case I do aspiration, but majority, yes, I do.
Yes, true. So CT not done. So this was the long link film. So now, how you manage, sir, Dr. Chatterjee, please, how you remove this well-fixed stem? What will be your approach?
Asking me? Whom?
Dr.
Chatterjee, sir.
Mukherjee, sir. Jatapati, sir. Next, quick, sir. Huh?
Tap, try to hammer it out. And if it doesn't come out, I'll do it.
So there are various methods.
You initially you will start with the cortical window. No.
Metal working.
Metal working? Yes, sir, Dr. Chat. Initially you will go for the ETO. Just quick, sir, please.
Fast, yes, sir.
My threshold for doing an ETO, it's not working. So my threshold for doing an ETO is very low. And I think the ETO heals very well. And otherwise, if you try to make a window and try to tap and all that, and then eventually go to an ETO, you'll have a fragmented window, which is much more difficult to handle. So
Dr. Shub, your opinion?
Any day. I can't think of anything else.
Can I add something?
Yes, sir.
Permit, if you permit.
Yes, sir, please, sir.
So remove the proximal part, pass multiple K wires all around. You might be able to remove it, that is one. Number two, or the corer. The corer means the hollow.
Trifine.
The
Trifine.
Trifine.
Yeah.
Trifine is another method if you have. In this case.
This is the well impacted, sir.
Yeah, I understand. Because the proximal is wide. If you can go past that, you'll be able to take it out.
no, Trifine works very well in a cylindrical stem. But in a conical stem, the Trifine is difficult because it is tapering in the opposite direction.
Very true. And
It's not a large fragment. It's a routine stem. It's a long stem. It's not a long stem.
so, quickly. So, this is the method already discussed. So, the second thing, of course, these are the instruments we usually carry out within our theater. And this is the cortical window, which I am talking about, that just make the cortical window, just have a carbide punch, the drill it hot, then back it, hammered it back. It might be possible to get. And if not, it is a method is well described by the Moreland. And if not, then we can go for the primary femoral osteotomy. It's not a ETO. It's a primary femoral osteotomy. Just slit it, use the tensile power of the initially bone and the slitted it, and then you can back it hammer. But be prepared, this osteotomy should be at the same place where you had planned for the ETO. If it fail, you can convert into the ETO at the same situation. The one thing. So, any experience, sir? You are not happy with this?
This will work very well if your stem is not broken, so that you can put in the slap hammer and take it out. You just want to decompress the cortex, right?
True.
But with your broken stem and the top part out, I don't know how you will reach that bit of bone which is lying below using this technique.
You can summon the wise plier and you can catch it in the mouth. It is possible, but of course, it is very true. If it is full stem, it's easy. But in this scenario, in the broken state, it's not possible. I'm fully agreed. So I have gone for the extended ETO as universal, no doubt about that one. So I did the ETO. These are the position, and the defect was type 2, Paprosky. Now one question, sir, Doctor, sir, what you will like to put in this stem in this kind? Paprosky type 2, what you will prefer, the cemented one, the proximal?
I think the Wagner stem will do very well here.
Yes, sir.
Typically, I would love to use the
Distal
Wagner
fixation, do it, Dr. Arora, please.
So after doing ETO, it has to be diaphyseal fixation.
Yes, sir,
After doing
diaphyseal
ETO,
fixation.
It has to be diaphyseal fixation.
Yes, sir, Dr. Shub.
Any distal fittings?
Tapered
Distal
conical
fixation, taper
stem.
fitting,
Tapered conical stem.
S-ROM, proximal fitting, no?
Out of question.
Questions?
Out of question.
You
Out of
so-
question.
Once you label Paprosky 2, even if it is
Out of question,
intact,
because you have done at ETO, then it's better to fix a distal fixation, Wagner type stem, it is the best stem.
That's right.
Very good, sir. So, as we know, I did this. Any comments, sir?
Well done.
Fantastic.
Right, sir. Thank you, sir. Again, I will like to all invite you in our IA 2025. Right. Thank you, sir. Thanks a lot.
Thank you.
Thank you so much, sir, for the excellent case presentation. I would like to call upon Dr. Preeti Ranjan Sinha for a case on conversion of failed hip arthroplasty to total hip replacement.
Nobody, 75 years old farmer with complaint of pain in left hip and difficulty in walking since last 1 month. He had a history of hemiarthroplasty done with osteotomy prosthesis for fractured neck femur 18 months back. Patient was a community ambulator before this surgery, but after the surgery, he had become household ambulator and had a very difficult walking with his prosthesis. So on examination, there was a healed surgical mark of size 12 into 2 centimeter over posterolateral aspect of proximal third of right thigh, extending up to mid third, healed by primary intention. There was no local rise of temperature, swelling, tenderness, sinus or fistula were seen. Range of motion of the hip was restricted. There was no limb length discrepancy. On blood investigations, the ESR CRP was within normal limits, TLC was 6.8, and other blood reports were unremarkable. So this is the pre-op X-ray. So on this X-ray you can see the whole stem is loose, is in varus, and the patient never had a good walk after the index surgery. So sir, I would like to want sir, Arora sir, what would your approach if the patient comes like this?
So we do apologize, I missed your first slide. It was done when? Just duration of surgery? 2 years, 1 year, 5 years? Duration of surgery?
Duration of surgery, sir, 18 months back.
18 months back. And it has been painful since very beginning.
Yes, sir.
So step 1, rule out infection. It was painful since very beginning, no matter how it looks, because we all tend to give a lot of antibiotics. It might be a grumbling infection.
But this is our pre-op X-ray. This is a pre-op X-ray when the patient came in OPD.
Yeah, I understand. So 18 months done, 18 months old hemiarthroplasty, which has been painful from day one. Approach would be rule out infection and revise. That is one. How to rule out? Get an ultrasound done, get an aspiration done, do cell count, culture, all those kind of things. And then we plan for doing a revision, totally arthroplasty,
Yeah,
not
yes.
bipolar.
No, sir, totally arthroplasty.
So number one, starting from very beginning, be careful when you dissect it, dislocate it. Don't try to rotate. You might create a fracture. keep bone hook handy, do all capsulectomy, and then you with the bone hook you take it out. That is one. Second, once you bang it out, because the metaphyseal area might be weak, you think of distal fixing stem, or if you find it is a good metaphyseal area, you can think of any stem like acrome, or any cemented, any stem you can think of, there is good metaphyseal bone. If metaphyseal bone is poor, you need distal fixing stem or a cemented stem. Cup, cemented, uncemented, your choice. Both work very well.
Sir, since ESR CRP were normal, so I didn't aspirate the hip. So, and what about the choice of implant, sir, in this case? As you told, but the patient was of low budget.
Cemented.
So,
Both the sides cemented, no problem.
so I thought we'll go ahead with primary THR set without, because there was no as such any proximal osteolysis or the acetabulum was looking normal. So we thought we'll get away with the primary THR.
No problem.
With primary implants,
No
no,
problem.
revision implants.
I can see metaphyseal bone is visible.
Yes, sir.
It might be osteoporotic, but it's visible.
Yes, sir.
So there will be good osseointegration. See, we saw one of the case where a cemented implants were removed and the cemented implants were put. That is not desirable. In the sense, here there is no cement all around. Because once you put cement, it integrates into the cancellous bone, and once you remove that cement, the cancellous bone is gone and you get cortical bone. So putting cement on a cortical bone is not desirable thing. And similarly on the acetabular side, once you remove a lot of cement, not much, bone is left which is honeycombed. So it's better to put an uncemented. But if money is a problem, then one can come.
Yes, sir.
No, that's why I asked for the case for discussion to show the slide, because that one case could have been done with cement in cement, but the author wanted to improve the acetabular position also. Acetabulum was vertical, so he thought I'll improve acetabular position also. Unless you have that in mind, we are talking of another case. He poked another question at me, so.
In this scenario, many times you are very difficult to get it out. At that time, you may need a ETO. So you just kept Wagner type revision stem in OT. I think this is yes, sir.
Shall I give him a tip? So what we call as articulotrochanteric distance. You look at the tip of trochanter with the pelvis. It is articulotrochanteric distance still maintained in this case. One can still see what we label as offset. It is still visible. So we'll get some place to work so we can dislocate. If you find that greater trochanter is abutting the pelvis, be prepared for an ET. Absolutely correct. Absolutely fine.
I think two techniques. One is that if you are going through the posterior approach, then you can just trim away a little bit of the thinned out posterior wall of the acetabulum to expose the head of the implant a little bit more, and then use a hook, a bone hook, or you could actually use that hole there with a smaller hook and then try to lever it out. What you must avoid is twisting the leg. If you twist the leg, you will get a fracture.
Yeah, and
Either acetabulum or the shaft.
if it goes towards protrusio, you have to remove slight rim of those acetabular marks.
So we went ahead with the same skin incision, and patient lateral position, soft tissue was elevated in mass because there was no differentiation found between the external uterus and capsule. Intra-op tissue was sent for gram stain, AFB, KOH, which all were negative. There was no collection of any fluids, and AMP process was removed easily with a hook. So distal canal was not open as there was risk of cortical. We just managed with the longest stem. So we didn't perforate the neocortex formed the tip of the processes. So hybrid total replacement was done. So in these two articles, recent article in 2024 in Arthroplasty Today, conclusion, conversion from hemiarthroplasty to 2HA generally results in improved functional outcomes, as evidenced by Harris-Hip score improvements. Despite the positive impact of Harris-Hip score, conversion THAs are associated with notable risks of complications. So another article by Pankaj Malhotra and Bhan from AIMS Delhi in 2008 in IGO, they also said conversion of symptomatic hemiarthroplasty, total hip arthroplasty is a safe option that gives good functional results. So my take-home message, this is the post-op exercise,
Yeah.
and this is the video of the patient walking. He is very happy while walking, as he was not walking after his index surgery.
We go ahead, Preeti.
So my take-home message is this article from OFA, SA and Ross, that they told that Performing conversion arthroplasty from hemiarthroplasty THA is associated with increasing risk of multiple joint complications in both the short and mid-term follow-up. So surgeons should always consider these complications when indicating hemiarthroplasty for femoral neck fractures for elective conversion arthroplasty.
Thank you, Preeti. Message well taken. There is a question just because we will have time later on. Did you encounter any difficulty dislocating or taking it out?
No difficulty at
Or
all, sir.
banging out the...
No difficulty at all, sir. It came out very easily. Once we removed the scar tissue from anterior and posterior stem, it was very easy to take out the stem.
How old it was?
Sir?
How old it was? The 18 months.
18 months,
So
sir.
many times the bone grows in between the holes. So, yes, sir.
It was loose, sir. Stem was
It was
loose.
loose.
Stem was loose.
The message is if there is any bone, and then what is your treatment plan at that time? If you got a bone inside and you are difficult to hammer it out, then what you will do? What could be the message of that?
Sir, I will
Very
prepare
young
for ETO.
You straightforward go for the ETO? Yes.
So,
Inostotomes down, this is what I say.
so till now, I've never seen bone grow between the two holes in an Austin wound. It is always fibrous tissue.
And strong fibrous tissue.
Strong fibrous tissue, so that the implant will rotate, but it will not come out.
So that's the message. So strong fibrous tissue needs something sharp to go anteriorly as well as
You can
posteriorly.
cut it
to
with a
break that.
sharp osteotome. Yeah. And the
Yes, sir.
worst case scenario
In case, not all case.
and the worst case scenario is if somebody has cemented a Austin wound.
Then you need Dr. Chatterjee to take it out. Not everybody can take it out.
After you remove, sir,
Yes. Dr. Sani, yes.
If this kind of processes is very tightly fit or having patient has to be needed to be removed, so I have taken one idea to make a hole by thick drill over the head of over the bipolar, and extractor, we have a extractor nail of wire and threaded it over the hole and take it out, because a good impactor you have to be draw and easily. I think maximum time जो tightly fit है वो इस तरीके से मैंने निकाली है.
He has strong assistants who can punch it from below.
Thank you, sir.
I was a resident. I was supposed to do all this.
So moving on now, we'll call the last speaker, Dr. Ankit Mittal, for a difficult case of THR. Dr. Ankit Mittal, is he over here?
Good afternoon, everyone. I am Dr. Ankit Mittal, additional professor in the Department of Orthopedics, UPMS Cephai Etawah, and I'd be talking about my case on total hip replacement in a 10-year-old neglected posterior dislocation of hip, who presented us with girdle stone arthroplasty. So, a brief introduction. The patient was a neglected case of posterior traumatic hip dislocation, which is not common in developing countries, not uncommon, and its treatment is fraught with great difficulties and controversies. Sometimes open erosion internal fixation is not possible, and excision arthroplasty, that is girdle stone, has to be done as an alternative. Variable and poor long-term functional results have been reported after girdle stone arthroplasty. Therefore, total hip replacement following girdle stone arthroplasty is needed to improve the functional outcome of the hip joint. So this case was a 24-year-old gentleman who had a history of injury to left hip due to road traffic accident 10 years back and was diagnosed as a case of posterior dislocation and managed conservatively and developed stiffness of the affected hip. This was the X-ray of the patient showing the unmanaged posterior hip dislocation, and for which he went elsewhere, and 4 years later, due to increasing pain and stiffness, difficulty in walking and difficulties in daily living, he was performed with girdle stone arthroplasty in 2018. This was a surgery performed by some surgeon elsewhere, where he just resected the neck to gain some mobility at the hip joint. After this procedure, he had some relief of pain and gained some mobility. And the patient developed a shortening of 9 centimeters due to continuous walking on the affected side. And he presented to us in a walking position where he was walking on his toes. His foot was completely plantar flexed and he was putting his toes only on the ground to compensate for the shortening. Hip flexion was only limited to 45 to 60 degrees and he was unable to squat and sit cross-legged. This is the walking video of the patient. The patient was unable to walk. Patient was able to walk with his toes only touching the ground and was not able to squat and sit cross-legged. The patient was not at all satisfied. So the solution that we came up to was total hip replacement to improve his quality of life and to improve the function of the hip joint. Now, total hip replacement is technically demanding. As there was limb-length discrepancy of 9 centimeters, the abductor mechanism was also dysfunctional, and there was bone loss, and clinical outcomes were unpredictable, and there were multiple implant options to solve the problem. So we kept the patient on traction for some duration, and we kept the option of subtrochanteric osteotomy in our mind intraoperatively. After applying traction and gradually increasing the weight over a period of time, we could reduce the shortening from 9 centimeters to 5 centimeters. And then after complete pre-operative planning and keeping all the available implants which could be used at our disposal, we resorted to total hip replacement and kept the possibility of subtrochanteric femoral osteotomy also. The patient was kept in lateral position and hip replacement was performed through the posterior approach. And first of all fibrotic tissue and capsule were excised. Acetabular exposure was done. Uncemented cup of Pinnacle 48 size was used, and solution stem in femur with 32 size head was used. And finally, we succeeded in obtaining reduction and completing the surgery without doing subtrochanteric femoral osteotomy. This was the post-operative X of the patient. We did tension band wiring of the femur, circlage wiring of the femur to prevent any intraoperative fracture while putting the stem. And we didn't have to do subtrochanteric osteotomy in this case. The post-operative period was uneventful. The patient had a post-operative shortening of 2 centimeters. The shortening was 5 centimeters before the surgery and 9 centimeters when he presented to us. And physiotherapy was started, range of motion exercises, quadriceps exercises on the second day. After 1 week, patient was advised to walk with the help of walker. And after 4 weeks, the patient was able to walk without any assistance. This video could not be played. This was the post-operative video of the patient after 3 months, in which we could see that patient was walking with some amount of short limb gait. So what literature says? Literature says that the pain function and range of motion greatly improves after total hip replacement. Surgery is technically challenging with high rates of complication, but the clinical outcome of conversion of resection arthroplasty to total hip replacement is comparable with conventional revision surgery. Conversion of a resection arthroplasty, even after several years, is a technically demanding procedure, and we believe that it can be undertaken with an acceptable low risk of complication. This was reported by Garcia et al. In 2014. Conversion from resection arthroplasty to total hip replacement, the soft tissues are invariably tightened, making proper testing of hip stability more difficult, and managing the bony defect aiming to recreate the center of the hip joint rotation may explain our low requirements for more constrained acetabular components. So we may not require more constrained acetabular components if we are able to recreate the center of the hip rotation. Incidence of femoral periprosthetic fractures is low and was limited to intraoperative proximal cracks, which can be treated by prophylactic or therapeutic simple circlage wiring. So conclusion, a conversion from resection arthroplasty to total hip replacement is technically demanding, and an acceptable level of risk of complication is there. The preoperative counseling of the patient must highlight the influence of the nature of the surgical procedure and the risk of potential complications. Despite significant improvement in the clinical outcome, patients should be warned that there could be a great chance of persisting limb length discrepancy after the surgery. The patient's expectations of improved hip function should also be tempered to a realistic level. Thank you.
Thank you very much, Ankit. Any message you want to give from this? Any single message?
A message that I would like to convey is that resection arthroplasty can be converted to total hip replacement if the patient is willing to accept a small amount of shortening, and we have all our implants and instruments at our disposal, and we should first of all manage it by traction so that we can reduce the amount of shortening that we have to compensate for intraoperatively.
Great, yeah, thank you.
I have one question. Yeah, I have one question. Why did you think that the hip abductors would be non-functional?
Since the patient was walking on the affected hip for a long duration, and the hip was proximally migrated, that's why I was thinking that might
He
be there.
wants to say not as effective, that was a thought, but
They,
they are
they
intact.
are usually functional.
He wants to say,
The abductors, they do work very well.
Very
And
well.
if you are thinking of a non-functioning abductors, then you should have gone for a dual mobility.
so still okay, they come
Usually
back.
they recover very well.
And I'm observing you had kept S-Rome in backup.
Yes, sir.
Why S-Rome? Because the femur was fine, absolutely fine, okay.
Yes.
It was the vestibular side which would have been damaged if the surgeon has done improper kind of resection arthroplasty. Femur was quite okay. So sometimes, I want to convey a message. See, sometimes if surgeons keeps S-Rome, if he anticipates difficulty on the vestibular side, to play around with antiversion. That's the only advantage.
Okay, sir.
Sometimes suppose we keep on getting tubercular in India, vestibular destruction, and you are not too sure how the version is. Sometimes you use S-Rome. You use S-Rome sometimes for vestibular reasons, to play around with the version. Sciatic palsy.
Yes.
Why was solutions?
But again, coming back, chances of sciatic palsy are less in adult pathologies because the nerve is already developed. It is more common in DDH where the nerve is not developed accordingly.
Why was a solution stem?
I
needed for
think the
this?
best way you do a traction, X-ray in traction, so that you can come to know how much the hip is going down and how much remaining shortening is there. Mostly it is within 3 centimeters, no doubt about that. There will be no sciatic nerve palsy at that time. If it's not going, then it may be. Yes, sir. What is your opinion?
Agreed, yeah. But with release you don't lengthen more than 3 to 4 centimeters. That's so very well presented, Ankit. Very well done. Yes. Thank you very much.
Thank
Any question for the previous talks? They're
I have
still
a
pending.
question, sir.
Why was solution stem needed in this case? Solution stem, why was it needed?
Solution stem. No. Again, in case the proximal metaphysis was too bad, then only. Otherwise, no.
Just
A
to
routine
obtain-
stem will do. But if it is osteoporotic, think of cemented stem. Solution stem, otherwise, also in today has fallen out of favor because of various reasons. We have done solution and now stop using solution because solution over the years gives you so much of proximal stress shielding that you lose bone. Number one, it's a technically challenging procedure to do a solution stem. Sometimes it gets stuck. You're not able to fully seat it. And then on the other end, if you tend to use the so-called conical tapered, if you're thinking of distal fixation, think of a conical tapered stem because that rather enhances proximal osteogenesis. So solution stem is gradually falling out of favor. Single, cylindrical, monoblock, these kind of stem, cobalt chromium stem has fallen out of favor. Because stress shielding, and a lot of cases happen because of wind viper effect. It gets osteointegrate distally, not proximally, it breaks. So a lot of problems are encountered with solution stem.
So just because the proximal metaphysis was weak, and if we could obtain some amount of fixation in the distal stem, that's why we got solution stem as an option.
Yeah, for distal fixation, you have two choices, either of these. But if I have to choose now, I choose a conical tapered stem. Beautiful, absolutely beautiful. Right? Thank you. Very well done, Ankit. Any question for the previous speakers?
Sir, what is the role of preoperative traction? Like we get many cases like neglected femoral leg fractures, posterior dislocation of hip like for 8 months, 9 months old. What's the role of preoperative traction? How much help that you get from?
So if patient is ready to lie on bed for some time, you will need less soft tissue releases when you go up. That's the advantage. You can still counter the shortening, but one has to be very careful. What I always think is pin tract infection, one should avoid that. So traction has a role in our country, yes. We get a lot of neglected trauma. If patient agree, I will like to put them on traction. If they agree. The problem is I live in a city where you talk of traction, he will leave me and go to Uttam. See, we have learned a lot in our country. Traction usually helps.
But sir, whenever there is strong fibrosis, traction will not help. What I did in this case, first I released all soft tissue all the fibrosis inside the joint, and then applied the traction. Again, the traction is applied above knee, below knee, sorry, and tibia, not in the femur. Femur is the same compartment. Sometimes the chances of infection is there when you apply cemented or uncemented
You are
stem.
saying 2 surgeries? You are saying 2 surgeries? One is
Yes, sir.
cleaning,
Cleaning.
traction.
And then if the, because the femur is higher up, is two.
I would not do that because any second surgery will increase chance of infection. I will not do that. Doing an arthroplasty, we are thinking of 25 years, 30 years. So anything which enhances chance of infection, I will not do that.
But in this, if there are strong fibrosis, traction is initially not help
It
in
usually-
preoperative.
Dr. Seni, it usually works, I can tell you from experience. See, I worked in government setup for 18 years. And from my institute, there is a textbook on neglected trauma by Dr. Anil Jain. You know that?
The traction works. I will vouch for it. And he has said that 9 centimeters, it came down to 5 centimeters. That's commendable. So why? And 5 centimeters is doable. We all know.
No, that's the correct approach if patient agrees.
I do appreciate releasing and doing a dissection in an old girdle stone. That's a tough job, and he has done it very well. So I'm really good.
Yeah.
Great case, Dr. Mittal.
Any question for the previous speakers?
Dr. Narendra, you mentioned about the prophylactic circless wiring. Has anybody done it?
I have done it. Sometimes because I tend to use coralline stem. Prophylactic. In a weak one. He's there to stop us.
If you are doing an ETO, then you must put a prophylactic wire below the